Alrighty, well, I'll go ahead and kick us off, and as folks join, we'll catch them up to speed. My name is Shannon Roberts. I'm a program manager with the Peer Recovery Center of Excellence. Cheryl Pacapelli and Alyssa Sage reached out a few weeks ago, wanting some trainings around strategic planning for New Hampshire's RCOs. So that's why we're here today. This is the first of 3 sessions. My colleague Chris Kelly is here with me. She leads our work group focused on RCO capacity building. So we've got lots of expertise in the room. And without further ado, I'm going to love the sound of kiddos. But without further ado, I'm going to actually hand it over to Sierra Castedo de Martel with Chestnut Health, who's going to lead this session. And I will be in the chat if you have any questions or if we are talking resources. I'll make sure to get links shared in the chat, and this recording will be shared out after the meeting as well.
All right. Thanks so much for the introduction, and congratulations on nailing the pronunciation. It is a challenging name. I get that. So thank you. Well, hello, everybody. Thanks for letting me share with you today. And thank you to Cheryl and Alyssa for contacting PRCOE to invite me in. I am really looking forward to sharing this with you today. I am really passionate about this area. Hopefully we can kind of demystify economic evaluation a little bit for you and make you feel confident in using the tool that we're going to talk about today. So it's early in the morning. We're going to talk conceptually about math, but I'm not going to make you do any math today. You are going to see like numbers periodically, especially at the end when we actually use the calculator. So I hope you have some coffee and it's not too boring. I'm going to try to keep it interesting. But I also want to say at the beginning, if you have questions, feel free to unmute. If you want to pop your question into the chat box, I think one of the facilitators, Chris or Shannon, can maybe unmute and ask it out loud if I don't see it. Since sharing my screen, I won't see the chat box too well. But I definitely encourage you to ask questions. We got 90 minutes today. We got plenty of time. So if anything's unclear, definitely, reach out and let me know. You'll get my email address towards the end. And if you are actually, using the calculator months or, even a couple of years down the line and you have questions, just feel free to shoot me an email too. So today we're going to talk about Economic Evaluation 101. I'm going to introduce you to this cost effectiveness calculator for peer recovery support services and bystander naloxone distribution. And I'm going to give you some worked examples so you can see okay, here's how I might get those numbers, and here's what it looks like when it, spits out a result at the end, and how I might use that information. So sorry, I guess I just gave you this overview already. I'm going to start out with some background though. So why we did this project, why we made these tools, what are we trying to accomplish here? Then we'll go into that Economic Evaluation 101 tutorial. Then I'm going to give you a little snapshot. I'm not going to go into super duper detail, but the analysis that I did to make the calculator, and some general results about peer recovery support services. That's what's going to get published in the peer-reviewed literature. It's under review right now. It's good to know, if you're writing up a grant and, they want that information cited, you can cite that. But that's like a more general picture. It's not going to be specific to your program like the calculator is. And the calculator is what we'll get into at the end. So starting in the background, going way back to the beginning. So I used to work as a collegiate recovery program director. I got sober in a collegiate recovery program. And then I had the good fortune of being able to lead that program at UT Austin. But we were a completely donor-funded program. And so I had to fundraise our entire budget every year. It's really hard. I'm sure you all know that fundraising is really hard. Some people are gifted at it. I'm not gifted at it. We did fine, but I'm not, it's hard for me. But I would get questions from funders periodically. What's the dollars and cents of collegiate recovery programs? Do they make economic sense? I had no answers, right? I certainly didn't have the skills at that time to be able to do that analysis myself. And then I also couldn't find it anywhere in the literature. There was no information in the literature. No one had done this work before. of figuring out collegiate recovery program cost effectiveness. And so I was a little bit frustrated by that. I happened to be in a Master's of Public Health program at the time. I took a class on cost effectiveness analysis, and I was like, you know what? This is not complicated math. It's stacked on top of each other in a complicated way because you build basically a mathematical model of a program, but it's addition, subtraction, multiplication, division, it's simple math just stacked together in a complex way. And I was like, you know what? This is doable. We have information about how effective these programs are. We have some information about costs. Like, we can make this happen. So I did a collegiate recovery program cost effectiveness analysis for my master's thesis. And my teacher at the time for that class, who I still work with today, including on this project, he had made a calculator for physical activity programs in schools, where a school that's really small, it's not going to get the same results in terms of cost effectiveness as a school that's really, really large, right? And so you can enter your own information in and get a customized result. And I was like, I want to do that for collegiate recovery programs. So I made an Excel-based one for collegiate recovery programs, and that kind of spurred on this work that I'm going to talk more about today. So we made that first cost effectiveness calculator for collegiate recovery programs. It was a huge hit. I wanted to make more of these. And ultimately, what we're working towards, one component at a time, is to make a very multifaceted one. So one with like 9 or even more components for all these different programs like peer recovery support services, like eventually recovery residences or sobering centers. So we want to have all these different components that people like you who are actually running these programs can use to look at your own program's cost effectiveness, use that information to get support for your program, and maybe even people who are making funding decisions, community substance use coalitions, they could also use it and help make better decisions about where they're going to direct substance use funds. So that's kind of the ultimate goal here, right? We got two audiences in mind. You're the primary one. And as a bonus goal, I'm a researcher now. So as a bonus goal, we're also helping to fill in some of these gaps in the research literature on economic evaluation of these programs, because there's not a lot. There's not a lot out there. And that's a lot of work. Here's a link to the collegiate recovery program, what I mentioned. We didn't have any funding for that, so it's just really simple, based in Excel. You can check it out later if you want. For my doctoral program, my dissertation research, that's when we built the calculator you're going to see today. And we actually had a little bit of funding to do that from the Recovery Research Institute at Harvard Mass General. If you've heard the name John Kelly, that's the one that John Kelly's at. He's a substance use researcher. So we had to first do the economic evaluation for peer recovery support services. No one had done that before. So we had to do that analysis. And then from that analysis, we translated it into a piece of a calculator. We also, for the first time, took an existing analysis that was already done, somebody else did it, and we translated that into a calculator so that you could plug in your own numbers, get a customized result. We actually did a ton of involvement from 2 different RCOs in Austin, Texas. They informed, how we built out that model. Again, the simple math, but that's stacked together in a complicated way. And then they also pre-tested every component of the calculator and gave a ton of feedback that we then incorporated into what you're going to see today. And this one, since we had money this time, we were able to bring in the IT department and they built it out for us. They translated it from what we built in Excel into a web-based, and it's ADA compliant. It's like way more user-friendly than my Excel-based one. So actually today, we have a grant going in. My part's all done. I'm just waiting for confirmation that it's in. But we have a grant going in to build out the next 7 additional components. So hopefully we'll get that. And so yeah, just to kind of walk you through what our process was for building this peer recovery support services and bystander naloxone distribution calculator. We got that funding. We did our background research. We had the recovery community organizations, Communities for Recovery and Recovery ATX. They're both in Austin, Texas, where I lived for 12 years before moving up to Detroit. We had them review every piece of the model. We built out our prototype in Excel. Then our IT wizard, Hannah, translated it to a web-based interface. Then we had the RCOs tested again, finalized all of their feedback, and we actually launched the calculator at NAPS, the National Association of Peer Supporters. Their conference happened to be in Dallas that year, so it was like, oh, just a jaunt up from Austin, and we were able to launch it there. And then we have a feedback survey up. We're still gathering feedback. Hopefully we get that grant and are able to incorporate that feedback in the near future. And yeah, we have a lot of plans where we're going to tackle this one way or another, whether we get that big grant or we have to hack away at it a piece at a time. We're going to keep moving forward because it's an area I feel really passionately about. So that covers the background. That brings us to today. And to make sure that you feel equipped to use and interpret the calculator itself, we're actually going to start with a primer on economic evaluation. And even though the calculator is specifically cost effectiveness analysis, and that's where we're going to spend most of our time, I do at least want to touch on other methods of economic evaluation. Just briefly, I don't want to throw any confusion into the works, but just enough so that if you're reading something or you get questions about something, you at least have heard of those methods and know a little bit about what they're about. Okay, so anytime that we have any kind of intervention, an intervention is just a very public health kind of word. That's what my grad education is in the public health realm. So intervention is just a word for a service, a program, an activity, some kind of thing that's addressing some kind of health problem, right? We just use the general term intervention. So you're going to hear me use that term a lot. So anytime you have an intervention, you have resources that go in to make that intervention happen. And then you have good stuff that comes out on the other side of that intervention. So that good stuff might be measured a bunch of different ways. In our field, it might be measured as maybe a reduction in drug use or sustaining abstinence. It might be measured in terms of employment outcomes, so getting a job, going back to school, housing outcomes, or something internal like I feel better, I have lower depression scores, I have higher recovery capital, right? So we can measure that good stuff in a million different ways. But we always have this flow. We have resources in and good stuff out. And so all economic evaluation is trying to do is to see how balanced resources in are compared to good stuff out. What's the balance between those two? Now, there are multiple ways of measuring or of assessing the economic evaluation of different interventions. And this top row is actually not telling you about that balance. It's really just telling you about one side or the other. And this bottom row is telling you about that balance. You may have heard of some of these approaches before, like cost savings or cost benefit analysis. Those get thrown around a lot. Sometimes you'll even hear these terms used interchangeably. They're not actually interchangeable, but that's okay. They get used interchangeably all the time, right? That's common usage. So here's what you need to know. So again, as I mentioned, this top row, cost of the illness, you might also hear it as cost of the problem. If there's something that says the cost of substance use disorder was blah, 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 $1 trillion, that's what they're talking about. They're talking about cost of illness. Cost of the program, kind of just what it sounds like. What does my intervention that I've designed to address that problem, what does it cost to run it, right? And then cost savings. Cost savings is kind of getting a little bit closer to this idea of balance. If I do this program and I address some of this illness, how much of that illness am I averting? I also am factoring in, though, what that program cost. cost, right? So from that overall savings, I'm subtracting out how much my program cost because those savings, that doesn't really count, right? So you might even be getting into some kind of complicated math. You're certainly bringing in a lot of numbers from a lot of sources. It's not simple, but they're also not telling you about that balance, right? They're not actually taking into account both sides of the equation totally, even though cost savings is getting you a little closer. So they're useful and important. People talk about them a lot. People are interested in these numbers, but they're not the full picture, right? So instead, let's focus in on that bottom row. And these are our economic evaluation methods that do tell us about that balance between resources in and good stuff out. So we're going to focus in on cost effectiveness for the rest of the talk today. So I'm not going to touch on it right now. We'll get plenty of time for that. But let's talk instead about cost benefit analysis. So just like it sounds, we're going to tally up all the resources that we put in, and we tally up all the good stuff that our intervention gives us. And we also factor in things like the cost of the illness or the cost of the problem, as well as that program's cost. And then we put them into a ratio. And basically we're trying to answer the question, what's the ratio of benefits to costs? Importantly, though, in this method, when we tally up the good stuff that comes out of our intervention, we're actually putting a dollar value onto that. And for return on investment, we're doing something really similar. For every dollar we put in, what's the dollar value of the good stuff that we get back out? And that, again, requires us to put a dollar value on all the good stuff coming out of our intervention. So I harp on that because, in contrast, cost effectiveness analysis does not ask you to put a dollar value onto the good stuff that comes out of the intervention. It just stays in the native units. So we're measuring the dollar value costs of all the stuff in, but we're not making it a dollar value. We're comparing it to the number of good things we get out, whatever the unit is, number of people in recovery, number of opioid overdoses averted, right? We don't put a dollar value to that. We just let them stay the way that they were measured originally. And here's why that matters. So assigning a dollar value to human life, to human well-being, it's a very philosophically hairy exercise, right? Health economists have put a lot of thought into that over many, many years, and there's some agreed upon conventions about how we do that. But what they tend to do is they're assigning a dollar value to years of life that the intervention adds, right? That's what's the really established method. We also know that, we don't want to look at just the number of years of life. We want to measure the quality too, right? Like a really invasive surgery is going to change my quality of life, but it might save my life. So I want to be able to adjust for that, right? What we're actually going to talk a little bit more about those quality of life adjustments later on, but we'll hold that for now. But so let's apply that to recovery. How good is recovery? What is recovery, right? Like we have a SAMHSA definition, we have a NIAAA, National Institute on Alcohol Abuse and Alcoholism definition. We have the traditional old definition of where it's just abstinence, right? But we've seen the definition of recovery change a ton over the years, right? NIDA actually just hosted a workshop to explore this in greater detail even. So if we're not like 100% sure on what recovery is, like we just last month had a workshop trying to figure out what recovery is, we're definitely not 100% on how good recovery is in order to be able to make that quality of life adjustment to those years in order to then assign a dollar value to it, right? So there's just this like cascade of uncertainty and change. And it feels really, really hairy to try to put a dollar value on any of that. So I like cost effectiveness because we don't have to worry about that. We can just let it stay recovery capital. We can just let it stay, number of people in recovery. We can let it stay number of lives, that were saved from an opioid overdose, right? We can let it stay in that natural, what it was originally measured in. We don't have to put a dollar value on it. And I think that's like really important at this stage of where recovery research is. So yeah, again, that's why I focus on cost effectiveness. We can be just more flexible with it. Before we go on and really dive in to cost effectiveness, I want to give an important caveat here. We as a society and as individuals decide to do things all the time that are not cost effective, that don't have a good cost benefit ratio, that don't make economic sense. We do them because we've decided as individuals or as society that they're worth doing, regardless of the cost, right? Regardless of that balance. And these tools are just that, they're tools. They're not the be all end all. They're another tool in the toolbox to make the case for your programs. So, if you're trudging along, entering your numbers in and you're like, I'm getting a lot of no's in this calculator. It's not cost effective to this threshold. Don't fret, right? Again, this is meant to just be a tool in the toolbox. Granted, spoiler alert, these programs are like wildly cost effective, especially PRSS. So like it's probably not going to be an issue. But even if it were, there's stuff that we decide that is worth doing all the time, even if it doesn't make economic sense. So again, just another way that we can make our arguments and get support for our programs. Also, I will say that if we don't pick up these tools are very often used against us. Lack of evidence is used as evidence of it being, of it not making economic sense, right? And so if we don't use those tools, we're really like leaving ourselves open as people in this field to have that used against us, that lack of evidence used against us. So I think it's important that we pick up those tools.
Hey, Sierra, can I
Yes.
hop in here real quick? We
Yeah.
got a question in the chat. Can you include the specific definition and approach to calculating cost effectiveness versus cost benefit analysis?
Yes, so we're going to get into the specific approach for cost effectiveness in detail. We are not going to get into detail with like the formula for cost benefit analysis, for example. But it is really not too different, except that you're assigning dollar value and then, having everything in dollars. But we're going to get really deep into cost effectiveness. Okay. So here we are transitioning into the cost effectiveness piece. So I told you conceptual math today, not too many numbers. So I apologize that I'm showing you a formula, but don't worry, we're going to walk through each piece of this. So here's the basic formula for cost effectiveness analysis. First, we're finding the cost of the intervention that we're interested in, whether it's recovery residences, peer recovery support services, whatever. And then we subtract out the cost of what we're already doing, whether that is specialty substance use disorder treatment, whether that is for naloxone, waiting for EMS to arrive with naloxone instead of having somebody, a bystander that has it. If it's a new flu vaccine, we're comparing it to the old flu vaccine, right? So what's the difference in cost between the new thing that we're doing and the old thing we were doing? Then we divide that by the difference in effects. What's the good stuff that comes out of our new intervention? What's the good stuff that came out of the old intervention, the old way of doing things? Now that we then divide those two differences, right? That's why there's this line here. And that gives us a result called the incremental cost effectiveness ratio, or ICER. That is the main result of our cost effectiveness analysis, and is something that the calculator will give you. But then we interpret that, right? We compare it to a few different things, and we'll get to that. Now, this is a ratio, right? I mentioned, we're not, it's a ratio just like cost benefit analysis gives you a ratio, return on investments giving you a ratio too. And so it's going to look like a dollar amount, and it's going to be of something. So it'll be, for example, for every sick day that this new vaccine for the flu prevents, it costs $10, right? Or for every person in recovery after a year, this intervention costs $20, right? It's going to be a cost per unit of good stuff. It sounds really funky. Well, let's take a trip to the grocery store for an everyday example of how we use numbers like that in everyday life. So we're at the grocery store, we're staring down the cereal aisle. There's a million different cereals. There's oats, there's rice, there's corn, there's sweet, there's not so sweet, there's healthy, there's boxes, there's bags, there's like really fancy Ziploc ones. It's like really difficult to compare, right? How do I know that this 10-ounce box is a better deal than this giant bag, right? So we can compare prices accurately in this environment when we look at the cost per unit, the price per ounce for cereal specifically. So here I've got a 15-ounce box of General Mills Cheerios, so name brand. Over here I've got generic oat brand cereal, but it's in a smaller box. So smaller box is going to cost less. The sticker price I know is going to be less, but do I know if I'm actually getting a better deal buying the generic? Well, I check out that price per ounce. It's 20 cents per ounce for the generic. It's 26 cents per ounce for the name brand. So yes, indeed, even though it's a smaller package, it is indeed a better deal to get the generic. Similarly, I can actually compare the exact same product, but just in different sizes. So here I have some Hunt's ketchup, same brand. I have a 44.5-ounce bottle and I have a 35-ounce bottle. Well, obviously the 35-ounce bottle is going to be cheaper, but is it cheaper per ounce? And actually, we think that usually if it's a larger container, that it's going to be cheaper, right? Like that's the whole Costco model. But actually, in this case, for whatever reason, the larger bottle is more expensive per ounce compared to the smaller bottle. So the smaller bottle is a better deal. Similarly, with cost effectiveness, we can compare, we can do some analyses at the end once we've built our models and run our basic numbers. We can take a look at, okay, if I, change this program that has 100 people, what if it had 1,000 people instead, and I changed all those inputs to match that effort? Well, would it actually be more cost effective? Or sometimes when you scale things up, they're actually not cost effective. It really only works on a particular scale. So we can answer those kinds of questions with a method like cost effectiveness analysis too. Okay, so we're back to our mathy slide with the formula. So that ICER is doing pretty much the same thing as that idea of price per ounce, right? It's price per unit of good stuff, whatever that good stuff is. Now that good stuff could be additional years of life that I get to live because of that intervention, or it might be days that I spend healthy instead of spending sick. And here's some examples right here, right? So maybe it looks like $100 for every person quitting tobacco or $20 for every sick day. Okay, so let's zoom in on this part of the formula, this idea of comparing to what we usually do, or treatment as usual. So we're always setting up our comparison to the current standard of care, what people would normally or usually get instead of your new intervention. An example, new flu vaccine compared to the old flu vaccine. Some new medication that has never existed before compared to no medication, right? Or maybe it's something that's a little bit closer. We're going to compare the exact same medication, but what happens if you add in exercise plus that medication, right? And with substance use, what do we normally get, right? What do people with substance use disorder normally get in a year? The vast majority of us. We get nothing. And that is unfortunately true. In any given year, the vast majority of people with substance use disorders do not get any kind of treatment, not a doctor's office visit, not a visit to an informal community-based peer support group like an AA or a Smart Recovery, nothing, right? And let alone, something like specialty substance use disorder treatment, right? So here's the thing though, if I'm comparing my new intervention to doing absolutely nothing, then my new intervention is probably going to look really, really, really good, right? Even if in reality, most people get nothing, I'm kind of setting up an unfair comparison. So what we sometimes have to do is to think about, all right, this isn't what people usually get, but this is what most people would ideally like people to get. This is kind of what the recommended care is. So we'll compare it to the recommended care or the ideal care instead of what people actually in reality in everyday life actually get. Does that make sense? It becomes more acutely an issue in substance use where, a lot of us are not getting anything. Okay, so now let's focus in on this bottom part. So to publish in academic journals, to kind of build up the authority and the evidence for this this line of research, and to really show the powers that be that like, no, this is serious. We really did the work. We need to be able to use something called a quality adjusted life year as one of the ways that we look at good stuff coming out. This also is actually just like that price per ounce metaphor in the grocery store. If I had Fruit Loops and I had Cocoa Pebbles, and instead of using price per ounce, I did it in terms of the price per Fruit Loop versus price per tiny little Cocoa Pebble, that's not really like directly comparative, right? I'm not getting a good comparison because those are really different sized things. They're totally different flavors. I don't know if they're made of different material, but they might be. So instead, if I do price per ounce, that's something that's more universal to all cereals, right? All cereals we can measure in ounces. So there's a similar thing going on here. I could compare peer recovery support services to getting a flu shot, right? I could directly compare them because I've reduced it to price per quality adjusted life year. Now that actually goes back to what I was talking about earlier. Cost benefit analysis and return on investment, they also reduce to quality adjusted life years. That's the main outcome that they're looking at. That is assigned a dollar value, right? So this quality adjusted life year is what that dollar value gets assigned to. Here in cost effectiveness analysis, we don't bother. We just let it stay quality adjusted life years. Okay, so year of life added, a life year, that makes intuitive sense, right? This intervention helps me live longer and, have a longer life expectancy. But it might be a little bit hard on me, right? Recovery is not easy. In year one, it's hot mess express, right? As I'm sure many of us are familiar with, right? So, we know it's not going to be like perfect health. Also, a lot of us in recovery have a lot more comorbidities than the general US adult population, both in terms of health comorbidities and psychiatric comorbidities. So, that's going to have some kind of impact on our quality of life. So we can account for that using something called a weight, quality of life adjustment. I'll just call it a weight because that's easier to think about it that way. Like it's weighing down or pulling up that 1 year of life, right? So if I had 4 years of perfect health added by my intervention, the quality of life weight that I'd assign it is 1. Perfect health is 1. So I'd multiply 4 years by 1 year and I'd get 4. So 4 quality adjusted life years added. If I had 4 years of life added, but it was a really difficult treatment of whatever kind, it really impacted my quality of life, well, maybe I have half as good quality of life now. So I'd multiply 4 by half and I'd get 2. So 2 quality adjusted life years, right? Now this is where this weight right here, this quality of life weight, this is where we really have no idea what to assign recovery right now. I actually had a little side project that I'm just wrapping up where I did, through some very complicated math, genuinely very complicated math. Ugh, definitely not going to put you guys through that. But I was able to map on to something that does give us this weight. So we'll be able to use those numbers in the future. But for a long time, we have not had a reliable weight and adjustment to quality adjusted life years for recovery. So how are you going to assign a dollar value to something we don't really know that we're weighing right? So that's again why we avoid those other 2 methods. Okay. So in addition to those quality adjusted life years, which are like, not the most intuitive, not the most interpretable, but we have to do them for research purposes and to compare to other stuff, to compare to wildly different types of interventions. We also want to do something that actually makes sense and is more meaningful to our stakeholders, more usable by our stakeholders, right? So that's where the RCOs came in to help us pick what that would look like, pick that effect of interest, pick that good stuff. And so that might look something like looking at the number of people who are in recovery at 3 years. When we're talking about long-term PRSS, we're really interested in long-term recovery outcomes, right? So we might want to look at effects in terms of how many people are still in recovery 3 years out. For bystander naloxone distribution, of course, an averted opioid overdose death, that is like clearly the perfect effect, alternate effect to pick out, right? Like, we also, for something like a vaccine, we might want to look at averted sick day instead of quality adjusted life years, right? Because we're just trying to keep people from being sick this year, right? So we have a lot of leeway in how we're able to measure that, what kind of effect we want to take into account down here. And it's really important that we get feedback from the people who are actually going to use this information as to what that effect should be. And again, no dollar value assigned here. We just keep it exactly in the unit that it was measured in. So let's focus in on the top part. In the top part, we're talking about costs, and so we assign a dollar value to everything. But it's all stuff that makes sense to assign dollar values to. No, we want to look at things 2 different ways. So in economics, in health economics in particular, in health economics in particular, we might want to think about things in terms of like costs that incur across society, right? People's time, people's productivity, criminal legal system costs, medical costs, just this really global perspective, right? And then we also want to take a much narrower perspective because our stakeholders also probably are thinking about things in that way too, right? Like, I want these big picture costs, but I also want like, what do my funders care about, right? And so we also want to look at something narrower. We can actually be kind of flexible with this too. We usually call it the health system perspective because that's usually the perspective that it makes sense to take. So, we'd only be looking at medical costs there, labor costs that are directly tied to the provision of care in the medical system. But we can, be a little bit flexible with it. The collegiate recovery program analysis I did, for example, right? In that cost effectiveness analysis, that narrower perspective was the college and university perspective, because they're the ones who are providing that care, right? They're directly responsible for administering a collegiate recovery program. So that perspective functions like the health system, right? For substance use disorder, it probably makes sense to go ahead and stick with like health system, healthcare, medical perspective, right? But we could narrow it down to like Medicaid only, or we could look at the whole healthcare system. Okay, so this is just a recap slide. And again, you're going to get all these slides. You're also going to get notes in each slide with, there's the notes section has pretty similar to what I'm actually saying out loud. So to recap, we have 2 different ways that we put a dollar value on this top part, societal and health system. We are not putting a dollar value on the effect side, this bottom part. We always want to look at quality adjusted life years and something that is meaningful, like number of people in recovery. On the cost side, everything gets a dollar value, right? Of course. And yeah, we've got those 2 perspectives. So we have 2 perspectives. We have 2 different ways of looking at effects. So that means we're going to have 4 of these ICERs, incremental cost effectiveness ratios, usually. We might have even more if we need to look at a bunch of different effects. We might have less if, for example, it doesn't make any sense to look at societal costs for this thing. We only want to look at medical costs, right? Or the other way around. All right. So let's talk about how to interpret ICER, our end result. What is a good ICER to have? So we actually compare that number, yes, to other types of interventions, but we also compare it to something called a willingness to pay threshold. It's a hypothetical or a real example of what a funder is going to pay, what a funder has paid in the past. So we have these like set standards in health economics, 50,000, 100,000, 200,000, or 250,000. I see both used. And those standards, this is kind of crazy. These come actually historically from dialysis. Back in the 70s, when we started covering dialysis under Medicaid, that is what a year of dialysis cost at that time, $50,000. These higher numbers, that is simply adjustments for inflation that most health economists try to also factor in. But we also, for whatever weird reason, still use that original 1970 number, 1970s number. And dialysis is required if you have end-stage renal disease. You cannot continue to live without it regularly. So if you have a year of dialysis, that is extending your life by a year. So that's how they arrived at, we know that the government is going to pay at least this much because they pay for dialysis. Now, peer recovery support services is very different than dialysis, right? So we also want to select something that's more meaningful to our particular health problem, that's relevant and comparable to our intervention that we're looking at. So for peer recovery support services, specialty substance use disorder treatment episodes make a lot of sense, right? We're already paying for people to go to treatment. There's grant programs, there's Medicaid and Medicare. We're already paying for it, right? The federal government's already paying for it. So what does that cost? So we need to find the price of that, and we can use that as one of our thresholds. So you want to pick something that's relevant too. So then we just compare our ICER to those numbers. It's harder to pass the smaller ones, right? If that ICER, if that end result is lower number, that's like a, it's harder for it to be lower like that, right? It means it's really cost effective. So if it passes the smallest one, then it's automatically cost effective to all of these higher ones. If it's cost effective, let's say it's $150,000 per year of life added. Well, then it would pass the $200,000 threshold. It's lower than that, but it's above these other thresholds. And yeah, that's what I just said. Below any of the thresholds, it's cost effective to that threshold. Now, sometimes you get a negative number, and this can be just a little bit tricky. If it's a negative ICER, because the top of your formula is negative, and the bottom of your formula is positive, so it costs less. So this top part's negative, but the intervention does more good, so the bottom's positive. If it's negative for that reason, that's good. That means it's cost saving and cost effective on top of that, right? For every year of life you save with this program, it's actually costing less than doing the alternative, right? So that's good. Now, this is where a little bit of conceptual math comes in. It can also give you a negative result if it's the other way around. If your top is positive because your intervention costs more, but your bottom's negative because it doesn't do as much good, well, that'd also give you a negative result. So you always have to double check. The calculator that I'll show you today, don't worry, it does that check for you. So it will tell you in plain language, is it negative for the right reason? Is it the good kind of negative? It performs that check already. And this is just a recap slide. So again, it's cost effective to whatever threshold that your ICER, your end result, falls below. And if it's below 0, it's probably cost effective and cost saving as well, but you want to double check that it's negative for the right reasons. And again, the calculator does that. Okay, this is getting more into more what we focus on for publication, but just to give you this information so that you have this context. If you read one of these studies, if you come across this kind of information in a report or something else, no two programs are the same, right? There's going to be variation, all sorts of different pieces that we put into the model. There's going to be different costs, different outcomes. One program might be wildly successful, while another one is just a little bit less effective, but still does a lot of good. We can explore those differences when we do the full-fledged cost effectiveness analysis or other economic evaluation. In fact, we're really supposed to, right? Doing our due diligence is doing these sensitivity analyses. It's, the due diligence is actually a really great term for it. It's effectively the same thing. So the calculator can do this first one. It's called the base case. Much like that name implies, this is like our basic model for a set time period, a snapshot in time. We're not looking at any uncertainty. For the, full-fledged analysis I did, this would be like an average picture of an average CRP, right? Cobbled together from all this information from around the country. Usually some kind of average or a median is what you're plugging in here. And the calculator will do this for you, for the average numbers for your program that you plug in. One-way sensitivity analysis is I take one of those inputs at a time and I change them across the entire range of possible variation. So a great example of this is labor costs, right? How much does it cost in different states, for example, to provide peer recovery support services for an hour of time? There's going to be a really low range. Unfortunately, Texas was one of the lower ranges. And then there's going to be a really high range. So I change that number and I see what happens to my end result, my ICER. How does that change cost effectiveness? You could actually do this at the calculator. I'm going to show you an example of that when we get into the examples. But basically what you have to do is you'll have to jot it down, jot your results down, jot what you change down, make yourself like a little table in Excel or just by hand, and you'd be able to do a basic version of this. And then probabilistic sensitivity analysis is really just something that we're doing for publication and academic audiences. Basically, what I would do is I would take all that uncertainty and I'd simulate it. I would run basically a simulation over 10,000 iterations. And then I would see what percentage of the time do I get a cost-effective result to those different thresholds. And so what that tells me is that in spite of all this potential variation, it's like when I let everything vary totally randomly over 10,000 times, still, 70% of the time it's going to be cost effective to that lowest threshold. Almost 100% of the time it's going to be cost effective to the next threshold. It kind of lets me see, what's the probability that any given program in the world would be cost effective. And so the higher my chances are that it's cost effective in that simulation, then yeah, probably most of the programs out there in existence are also cost effective. That's effectively what we're trying to convey with this kind of analysis. And so you'll actually get to see what that looks like in just a minute here, because I'm going to next move into showing you that analysis that I did for peer recovery support services, and just give you a brief snapshot of those results. But before I move into that, are there any big questions right now that we should address?
Yeah, Sierra, we had another question in the chat and calculating, I call it quali.
Yeah, quali.
Clearly, it's important to have solid data. What sources can be used to do so?
Yeah, okay. So for the calculator, you won't need to estimate your own quali. So the quali weights, I mentioned that I have, putting the finishing touches on a project to like zero in on that weight. Some of the best data we have is actually, y'all might already be familiar with this, SAMHSA-GPRA data. That has a quality of life measure in it that until very recently could not be used to estimate a quality weight, that adjustment, that weight number that we'd multiply the life years by. That whole project was about making an algorithm so that we could map those two things together. So there's a mountain of GPRA data now, right? With that quality of life measure that now maps on to a utility weight. So hopefully once I'm able to like publish this and get it out there, we'll be able to use a lot more of that mountain of data. I actually use the National Recovery Survey to get just a baseline estimate, but now that there is an algorithm to map between the two, that's going to come out with the paper. Like everybody will have that access to that code. If somebody really wanted to do their own from their own GIPRA data, it'll tell you which items to pull out of the GIPRA, and then it has all the code to make that conversion and get your own quality weight. You would then probably have to do your own analysis because our calculator doesn't let you change the quality weight because you don't need to change it typically. But hopefully for advanced users, I could definitely give backdoor access to our Excel version because it wouldn't be that big of a deal. It's just not as user friendly as the web-based version. But for general audience users, all you need to give us is, and you'll see this in a minute, performance in terms of retention of people. Like, are they actually, if this is long-term PRSS, so are they engaging long-term, right? They're not terminating before they're done with the program, right? And then also, what proportion are in your definition of recovery? So abstinence or reduced sustained use, both are accommodated in this. What percentage are still in recovery after a year? So you don't have to figure those out on your own. It'll estimate qualities for you from those two numbers. So nobody's asking anybody to do qualities, don't worry. But if you want to, you'll soon have the tools, and I'm happy to share some of that stuff in advance as well, if any advanced users want to do that. Okay, so for this analysis, I just want to acknowledge my other research team members. Hannah Wang was our IT wizard. Huge shout out to her because that's the whole reason we have the beautiful calculator you'll see later. And then a huge thank you to Communities for Recovery and Recovery ATX as well. And we did this all at UT Health. Okay, so as we just went through in great detail, here's our basic cost effectiveness formula. And this chart is basically just showing you how I arrived at ICER for this analysis. So remember that treatment as usual needs to be the current standard of care, even if sometimes, like in the case of SUD, people don't often get the actual standard of care. So because it would kind of be unfair, it would be like overly rosy picture of PRSS. If I compared PRSS to what people actually get, which is nothing. Instead, I set this kind of artificially high starting point. People get specialty substance use disorder treatment in this simulated cohort. Then they would either get a year of long-term, low-intensity peer recovery support services. So that's about an hour a week of peer recovery support services, roughly. Or they would just get treatment, rely on the effects of treatment, because treatment does, have some positive outcomes, right? They would rely on those treatment effects only. After that year, some percent of people will still be in recovery. Again, that's defined here as abstinence or sustained reduced use. And that's drawn from a big study of long-term PRSS in Texas, which was the best long-term PRSS data we could get our hands on. Or, in this condition, it would be the percent who go to treatment and are still in recovery after, right? So that's a little bit lower than PRSS, but it's still some percent are for sure. Some percent have returned to chaotic substance use, and then some percent have died. And we incorporated in here things like if you've been abstinent for a while and you take opioids again, you have a higher chance of passing from opioid overdose, right? Your tolerance is lower. So we were able to incorporate some of those additional mortality risks into this. These percentages are going to be different between these two groups, and those differences give us our differences in costs and our differences in effects. And we looked at effects two different ways: quality adjusted life years. It says discounted here. Discounting means, so it adds years of life to somebody over their whole lifetime, but we have to value years of life it adds right now a little bit more than we value years of life that it adds in your like 80s and 90s, for example, right? So we put a little discount on stuff that happens further out. And we also looked at the number of people in 3 years, who were in recovery still at 3 years. And we chose 3 years because previous research that looked at people in recovery over 8 years after treatment, it showed that at about year 3 of continuous recovery, the risk of returning to chaotic substance use, it was stable at that point, and it didn't change a ton after those 3 years. So that's like really where it kind of plateaus. So that seemed like the key point to really focus in on is like, okay, we can call this like they're way less likely to return to chaotic use after that. There's still a chance, but it stabilizes. And this is where we brought in RCOs at this stage. We designed this model, had a lot more detail, like, wrote it out as a formula and everything. And then we walked it through with our RCO colleagues, step by step, plain language, and gave them this primer, a version of this primer on economic evaluation beforehand, so we'd all be on the same page. All you really need to know from this slide, this is the base case cost effectiveness. PRSS is completely unsurprisingly cost effective to all thresholds that we looked at. And when we ran our big simulation, our probabilistic sensitivity analysis, it was cost effective to that lowest threshold, 60 to 70% of the time, and almost every time by that first standard threshold. So these are very cost effective, and they're very likely to be cost effective regardless of the differences between programs around the country. And then a key takeaway from the analysis itself, this one-way sensitivity analysis, peer worker wages, didn't have that big of an effect on overall cost effectiveness, right? So if you jacked peer worker wages way up, it was still really cost effective. What actually mattered way more was how effective are these programs, and are we retaining people throughout through actual long-term PRSS, right? Or are we losing people too early? And if you want to nerd out and dig into all the super details, you can scan that QR code or go to that link. Naloxone, again, we pulled that from an existing study. We did not come up with a study ourselves. We just found a study out in the literature, and we pulled the pieces out to make it a calculator. And we ran this model by the RCOs as well. It's a little simpler. That second step after the event, so there's an overdose, a bystander gives them naloxone, or they have to wait for EMS to arrive. In the second step after that event happens, we don't look at recovery. Certainly some of those folks will enter recovery at some later time, but we just don't know enough about what that pathway looks like, and like what percentages of people might go into the recovery pathway after an overdose event. We don't know enough about that yet, so we didn't want to model it. The more focal important thing here is just about saving lives, right? Preventing overdose deaths. So averting those overdose deaths. So we just looked at those two outcomes. Okay. Any questions about those results and how we set things up? All right. So let's move into using the cost effectiveness calculator. I am not going to go through all of these points, but you will have these handy as a reference. These are the inputs you'll need for the peer recovery support services side of the calculator. Excuse me. These are the inputs that you'll need for the naloxone side of the calculator. We pre-tested all the calculator components with our RCO friends. We walked through it as a group, and we also had them play around with it on their own on their phones, which you'll get to do in a minute. And then just so you know, behind the curtains, this is just one of 14 tabs in the Excel prototype of the calculator. It is tens of thousands of cells. It is doing a lot behind the scenes. It is kind of a miracle that our IT wizard was able to translate all of this into HTML. So there's a lot of really complex number crunching happening behind the scenes, but from your end, it should hopefully look much simpler. And a quick thank you to Cheryl and Alyssa from Harbor Care for letting us use their numbers for the Peer Recovery Support Services worked example. And I also want to give a huge thank you to Nice Project in Austin, Texas. They're an naloxone vending machine project. I ran some numbers for them a couple months ago, and they let us use them for this. So let's go to the calculator. You can go ahead and scan this QR code with your phone. It's mobile friendly. Or you can simply type this in, or I don't know if one of y'all, Shannon or Chris, can drop this into the chat box. Thank you. And I'm going to switch my screen over after just a couple seconds to make sure y'all have time to get there. Okay, I'm going to switch my screen over. And actually, what I'm going to do is share my whole desktop because I want y'all to be able to see some inputs. That's probably pretty small. And then the calculator is right over here. Okay. So I put the naloxone numbers first, but we're actually going to go ahead and do the PRSS ones first, and we'll go back to the naloxone ones. So here are the numbers from Harbor Care. And they match up to these inputs. But let's actually do a quick orientation first. So at default, we'll take you to the PRSS tab. You can just pop on over to the naloxone tab if you want to use that. You can also pop on over to the tutorial and resources. There's a webinar we recorded in probably of like November of 2022 or something like that. So it's a little bit older. I've certainly had more practice doing these tutorials since then, so feel free to reference that or reference these slides, whatever you want to do. Contact info and feedback at this link as well. Okay, so here we are at the PRSS calculator. Our inputs are how many people served. We actually mean in a year. In general, when you're looking at this, always by default, just think of a year as kind of our time period that we're interested in. If you want to, if your organization's been around for 15 years and, maybe you had tremendous growth in the last 5 years, but COVID was really weird, so you don't want to use that couple of years. You could average out across 5 years how many people you serve per year. You could just go ahead and go with, just the, July 16th, 2024 to July 16th, 2023. You can do it however you want. But we mean like in a year's time period. What percentage of participants are retained to 1 year or to successful completion of long-term peer recovery support services? So when we're doing these kinds of analyses, we're modeling things as 1 year time cycles, right? Because that matches up to our 1 year of life extension, right? The quality adjusted life years. But we got feedback from our RCOs, right? And I'm sure y'all have probably had a similar experience where like long-term peer recovery support services, like depending on the person, they could be successfully done with long-term peer recovery support services in 6 months or 9 months, right? Or for a different person, that might look more like 5 years, right? So the outcomes that we looked at, what's going on in the background, is based on an average between 9 months and 12 months, right? Like what happens to a person in that time. So that's why it can accommodate, a year or successful completion. If they're going out longer term, great. If they ended earlier than that, that's also great. What percentage of your people like finish, get to mark the graduation completion box in the GIPRA, right? So what percentage is that for your program in a year, right? Or average over 5 years, whatever you want to do. Of those you retain to that 1 year mark or to graduation, who's still in recovery? What percentage are still in recovery? Again, what the background calculations are doing is based on abstinence and reduce sustained use. So a sustained reduction in use. So a person might still be using if that's, in line with their definition of recovery. Maybe they're somebody who has an opioid use disorder and they're still occasionally drinking in a low risk way. That would still count as recovery if that's their definition of recovery, if it's not chaotic use, right? So what definition you guys use? If you use abstinence, great. This is probably a little bit of an underestimate then, but that's fine. Average age of participants. We need that so we can run those background calculations around mortality. Mortality risk changes with age. That's why we ask for that. You'll see here in this helper text, we can actually only handle ages 20 to 54 right now. In future versions, if your average age, if you serve older adults or you serve, adolescents and really young adults, hopefully we'll be able to accommodate a larger range. But I mean, the average age of the treatment population in the US is 38. So we hoped that was a pretty good range to provide for now. This gets in here about estimating labor costs. So we ask you to tell us the average number of engagements. How many times do they meet with their peer worker over that 1 year or successful completion, right? What's the average number of engagements? And then how long are those engagements on average? If peers are doing paperwork after each meeting, how much time does it take for them to do that on average? If it's like quick 5 minutes of paperwork, go ahead and add that into your average time. If it's longer, if it's like a half hour of paperwork, definitely make sure to add that in. And then what's the hourly pay for peer workers at your organization? And then I'm just going to show you real quick what it looks like when you hit submit. A bunch of different results will pop up, including some of those plain language interpretations of thresholds that I was mentioning before. Is it cost saving? Remember, it's a negative ICER for the right reason. In this case, it's not, so that's totally fine. It doesn't have to be, but it is cost effective to all these other thresholds. And then this is telling you how it compares to really, really different types of interventions. Lung transplantation, hypertension, right? Treatment of hypertension. So yeah, so it's kind of showing you how it stacks up. And that's a really cool thing about cost effectiveness is we can do those types of comparisons. So let's go back to Harbor Care. And I know that y'all had a little bit of difficulty in getting some of these numbers when we designed these inputs. Recovery Link was able to give, that's one of the data providers. They were able to give these numbers really easily in that older version of the platform. And I know that there's been some changes since then. Some of these numbers, you have to do a little bit of math to get them. So we have some notes in this column about how some of these were taken. And yeah, we can go ahead and enter them in. And Cheryl or Alyssa, if you want to chime in at any point while we're entering these numbers with like, hey, that one was really hard to get, here's what I had to do, please let us know. So let's go ahead and enter in people served. So 3776. And percentage of participants retained to 1 year, 65%. Of those retained, how many are in recovery? 79%. Yeah, could not match 1 year length of engagement sample includes active participants engaged in calendar year 2023. Yeah. Go ahead, Alyssa.
Both of those metrics are a little difficult. The second one, what percentage of participants are retained to a year, and then the one right below that about again that year-long benchmark. So if you guys remember in the old recovery link, we used to have a field in there that gave us length of engagement. So if we still had that, that would have been super easy to calculate. We could have just filtered for a length of engagement of a year or more. We don't have that anymore. And all of our session types are broken up into different reports, right? So like we would have had to pull all of the intakes, cross-match each participant to their most recent engagement through a slew of hundreds of other reports. I didn't do that. So you can see for this second one, total percentage of participants retained to a year, I just took a sample of those people. So I tracked down all of our participants that had intakes in January and just stuck with that one sample. So of those participants that had intakes in January, how many of them were still actively engaged come December? And that gave me, you can see the fraction there, 57 out of 87. So I just applied that percentage to our entire sample size because I couldn't track down all 3,000 people. And the same thing with this third one. Again, that 1 year length of engagement was really hard to match. So I used a sample of our 3,000 participants to just come up with like a standard percentage and applied it to everybody. So not perfect. I'll complain to Recovery Link to try and get these metrics easily for us, but
I know Robert's used it for Unity, and I know that they really like the calculator. So hopefully they're working on being able to make these numbers easy to get because they like it, and I think they would probably also like their Recovery Link users to use it. So hopefully they'll change it back or add in a new field or something.
Yes.
And here's the other thing though, if you are really banging your head against the wall and you're like, I cannot figure out how to get this number, you can, if anytime that there's an EG in that helper text, that is the default number that we input into the base case for that published paper, right? Everything except the number of people served. We used the whole US treatment population. We didn't use, for the calculator, we just threw in 1,000, right? That seems like a nice round number to use as a default. When you hit the default values button, it'll populate all of those fields. But what you might want to do is, as you're going along, okay, I cannot figure out this number, so I'm going to use the default here. But I'm not going to use the default in the other ones. I'm going to use my numbers, right? So you can do a mixture of default values and your numbers. That is okay to do. Okay, so we put 65 in here, great. 79 there. Average age of participants, 40. And then average number of engagements, 9. Average length of engagements, 45. And hourly pay, 20. And here are our results. Sorry, go ahead.
I just wanted to speak to the average length of engagement.
Yes.
So I totally guesstimated on that for you guys. So I did calculate the average engagement length, but then in terms of the additional include hours of data entry and paperwork that you guys fill out, I just put in an additional 10 minutes for data entry. That might be lowballing it, especially for the intake. I'm sure the intake takes longer than 10 minutes to enter into Recovery Link, but I just I lowballed you guys there, so hopefully it's more than that, but
that's okay. Okay. Well, thank you. And so here's our results. I have typed up a few little blurbs of how we might, plop that into a proposal, but let's go ahead and look at what it looks like on the calculator first. So I gave you that quick whirlwind tour first. I did not point out that there's actually 2 tabs of results. Remember, we look at costs 2 different ways, that broad perspective and that narrow perspective. So it defaults to show you the broad perspective first, societal. Up here, we have some stuff that's interesting that you might want to put into a proposal or into a report, but it's not the actual incremental cost effectiveness ratio, those ICERs. It's not those actual results. These are just things pulled out from the calculations that we have to do to get to that ICER, right? But they're interesting, so we put them right up at the top. So the first one is averted cost to society. Our whole program, with the inputs that we put in, it saves society this much. That's pretty high. $5.4 million ain't bad, right? Then we also just simply divide that by your number of participants, and that gives us a per person societal cost savings. We also give the total number of quality adjusted life years that our program added. for those 3,000 people per person life years. And then the number of people who we retain in recovery at 3 years compared to if all of those same people had just gone to treatment only. Now here are our ICERs. You've got a negative ICER for both of these, both in terms of quality adjusted life years and in terms of people in recovery. And they're both negative for the right reason. So earlier, when I ran the default numbers, this last one was no. This last one is now yes. It is both cost effective and cost saving. And here's our little comparison. Since it's a negative number, this little triangle doesn't actually go any further down, but it sits right at 0. So that's good. When we look at the health system perspective, our interesting results up at the top are averted medical costs, per person averted medical costs, and then kind of the same set of things. Our ICERs are going to be different in the health system perspective because remember, the costs that we're looking at are different for this perspective. So our ICERs are different, but the end result is actually the same because they're both negative for the right reasons. So actually our end result is the same, just the actual number value changed. So let's look back over at the slides. I've typed this up as some suggested ways of interpreting it. For every person in recovery at 3 years, 14,000 societal costs are saved. In other words, it's not only cost effective, but cost saving. I also add in some example text about how you could talk about that very top number, the societal or medical costs saved and per person costs, and then also pulling out some of those effects side things. So we keep more people in recovery compared to specialty treatment alone. So that's just some examples of what you could say. And we're going to go back over here to NICE project, and we're going to try out some naloxone numbers. So let me resize all of this stuff. The naloxone calculator, way fewer inputs. Unfortunately, we know that one of the inputs is a little bit confusing, and we know we need to change it, but it still works and is okay for now. We just have to keep in mind, unfortunately, that we have to assume that about 20% of the population, based on existing studies, about 20% of bystanders who might be in the vicinity of somebody experiencing an overdose already have naloxone. So if we want 100% of people who walk through our doors to get naloxone, we actually can only add in 80 because 80 plus 20 is 100. So it actually maxes out at 80. But that means the same thing as saying everybody who walks through the doors, I want to make sure they have naloxone. That's what I'd put. If I want to just make sure that only the really targeted people, only people who maybe live with somebody who has OUD, and that's maybe 10% of our RCO base, well, then I just put in 10%, right? And then cost of naloxone. So even if you get your naloxone for free, what does it? You can run it at $0. You could do an analysis like that. But it's actually informative to run it with the cost that it was to what it would normally cost, right? So normally this would cost $18 from this supplier, but because we have a grant that pays for it, so it doesn't actually cost our organization anything. Well, the naloxone still cost $18, right? Your grant paid for it, yes, but it was $18. So that's the number that you would enter. So I ran a few different scenarios. I did a very basic one-way sensitivity analysis for Emily at NICE project based on the $18 a dose 3 milligram formulation and the $24 a dose 4 milligram formulation. Oops. And then I ran a few different distribution scenarios. So just 10% of the people walking past that vending machine picking it up, 25%, 50%, and 80% because that gets us to 100. I made this little table. I just, jotted down the scenario that I was running and then what the outputs were. So the differences in costs, the number of quality adjusted life years or qualities added, the incremental cost effectiveness ratio result from that, lives saved, ICER, And then what it means, bullet points you can use in the proposal. You don't need to this is like much more formally written up because she was about to plug it into a proposal that was going in really soon. So I wanted to make sure to have citations and stuff ready for her to go. I'm not going to walk through all of this, but I just going to point out a couple of things. You'll have these slides again if you want to pick this stuff up. I did included a couple of comparisons to things that that people are already doing, but are actually more expensive, right? So medications for opioid use disorder, methadone specifically, it's a little expensive, especially compared to naloxone. I mean, obviously it does a different thing. It serves a different function. It's still cost effective compared to opioid use disorder, right? But it is, it's a little bit more costly. So it's reasonable to compare to things that are kind of similar, but that cost a little bit more money if you could find that stuff in the literature. And also if you want any help with that, certainly for naloxone, please feel free to use these exact same references. But if you want any suggestions for PRSS, feel free to reach out. Okay, and I'm going to X out of that and make this the focus again. Let's go ahead and run one of the scenarios I drafted up for Emily and hit submit. And it's set up somewhat similarly, except we don't have two perspectives here. We just have the health system perspective, because so much of because a fair amount of this is the intervention that we're comparing it to is EMS showing up, right? So it's just much more health system focused. So it's a little bit simpler, the set of results that you get. You still get the plain language interpretation. Is it cost effective to this threshold or that threshold? You also get the interesting results pulled out. What's the comparison in terms of costs and the difference in those costs? And you also get the comparison to other types of interventions. All right. And I'm going to stop sharing my screen for just a minute so I can switch back to the slides. While I'm doing that, are there any questions? Does anybody have any questions about any of that?
Hi, Sarah, we got another question. Is there a way to adjust engagements if less than a year?
If they were engaged for less than a year, but they successfully completed the program, right? If that was a successful long-term engagement, but it only lasted 6 months and they're in a good place, that's totally fine. That is why it says to a year / to completion graduation, right? If you would mark them off as having completed when you're doing your SAMHSA GPRIS, then totally that's you would count that as a successful completion. Because we know not every episode of PRSS is going to be the same length. People's needs are different, right? I'm happy to take more questions, but I wanted to make sure not to forget to do this. So if you want to scan the QR code with your phone, or maybe we can drop the link into the chat box. I know PRCOE would be really appreciative if you could take their feedback survey. And any other questions in the meantime, I'm happy to answer while you're working on that. Okay. We also have a survey for the cost effectiveness calculator. You certainly do not have to take it, but if you used it, or if anything's you really hate anything about our inputs and you think it should be changed right away, definitely drop that information there. Or if you're using it hands-on and you run across something that could be improved, definitely let us know. And there's my email address as well. And that is all I have. Thanks so much, everybody.
Thank you, Sierra.
Thank you.
I just wanted to add, I'm getting some questions in the chat on like how RCOs would get these numbers from Recovery Link. I'm happy to help you guys grab these numbers out of Recovery Link for your individual centers. The numbers Sierra showed were statewide for calendar year 2023. I can also definitely designate time at our next data quality community forum to show you guys how to grab those numbers out of Recovery Link and actually demo them as well, if that's helpful.
Great. All right. Well, thanks, everybody.
Thank you so much, Sierra.
Yeah, thank you, Sierra. This was great. And I think Shannon, when's our next?
I was just putting that in. It's August 13th, same time, same day of the week, identifying true program costs in your RCO.
So I think with this information that Sierra showed today, and then being able to identify true program costs, it really gives a foundation for RCOs to start to demonstrate to funders that what's coming in and what's going out, that we're making a fiscal impact as well as the heart-centered impact that we all know that we have. So excited to assemble some of these puzzle pieces with all of you. And I think we have some good email addresses in the chat if you want to follow up with any of us, ask more questions. And like we said, we'll get the recording out so you can share it with your larger teams. And just super excited and glad you all spent this hour and a half with us this morning. So thank you so much.
All right. Thanks, everybody.
Bye all.
Thanks, everyone.